Good evening. I'm Warren Hammert, and on behalf of my co-moderator for this webinar, Carrie Betlak, I'd like to welcome everybody to the AAHS APP webinar series. This is our second webinar beyond carpal tunnel. These are recorded and they'll be available for viewing later on the AAHS website, and certainly the previous one that we did would be available as well. So you're welcome to go back and review any of these. I think we have an outstanding program for you tonight. We're going to really be talking about peripheral nerve conditions. Carpal tunnel is kind of the thing you think about, but there's a lot of other things that will be touched on. And what we want to do is kind of review ways to diagnose this and then think about how you take this information and input it into your practice. So I would like to introduce our speakers. Starting off for us will be Dr. Chris D. from Washington University in St. Louis. He's a upper extremity and peripheral nerve surgeon. He's going to talk to us about electrodiagnostic studies, how to use and interpret these. And we're going to follow that with Dr. Neil Lee, who is an upper extremity and peripheral nerve surgeon at Duke University. And he's going to talk to us about understanding ultrasound and utilization for upper extremity peripheral nerve conditions. And then we're going to round this off with Miss Megan Harari, who's a nurse practitioner at Yale University. And she's going to talk about how we take all this information and input it into clinical care and provide the best care for our patients. If anybody has any questions, please put them in the chat. We'll have some question and answer as well as discussion, either after the presentations or at the end, based on how time allots for us. So with that, I'd like to turn it over to Dr. D and have him share his screen, and we'll talk about electrodiagnostic studies. Chris, thank you.
All right, thank you, Warren. I appreciate it, and thank you to Grace for organizing and Carrie for the invitation as well. Warren, if you could just give me an audio, yes, you can see my slides.
Yes.
All right, excellent. So we'll get started. I wanted to present this topic that Warren and Carrie asked me about understanding electrodiagnostic studies. I am in practice at Washington University in St. Louis. I'm fortunate enough to work with David Brogan, who we recruited back to St. Louis in 2018. And then we were also fortunate enough to recruit back one of our former fellows, David Wright, to join our WashU orthopedic nerve team last year. And we are always looking for new ways and opportunities to collaborate with our plastic surgery colleagues here at WashU. So you can see us here at combined nerve education courses, and who knows what the future will hold. So I think that when I first started learning about this topic, I read this chapter back in Dr. Gelberman's classic, but very old now textbook from 1991. And this is from Dr. Lee Dellon, who is a legend in nerve surgery. And I think this quote is really helpful. For your EMG and nerve conduction studies, put in your consult only when your careful history taking and detailed sensoromotor testing indicate that electrophysiologic testing is necessary to answer a particular question. Have confidence in your clinical skills that your judgment, not Dr. Electrophysiology's printed report, will be the final authority. So these are an extension of your physical examination. So don't rely on it to make the entirety of your diagnosis. I think all of you, if you have interest in this and have logged into the webinar, have the clinical skills to get to the same answers. This just helps to have some additional information to corroborate your clinical exam. But whenever I start to talk about this with our residents, fellows, and students and therapists in clinic, everybody is totally overwhelmed with what to do with it because it is a pretty intimidating topic to try to digest. And I do owe a lot of gratitude to the surgeon that Carrie works with, Dr. McKinnon, who taught me a lot about how to interpret this information. But the underlying principles are that the nerve studies are a tool to complement your exam. The nerve studies are imperfect. They are as good as the person doing the nerve test, and their usefulness relies on that interpreter as well as your interpretation. So, like everything we do in the practice of medicine, it very much requires that you are looking at things from all angles and really appreciating some of the limitations that each of these tests have. So the essential questions that I want to answer are: where is the nerve injury or nerve compression? Are there any other lesions going on? How severe is that nerve injury? Is there a chance that there will be any recovery spontaneously? And if not, what are my options? And for all of that, you need to combine both your history and your exam with your nerve studies and perhaps imaging as well. So in terms of thinking about this nerve test, it's basically looking at how long it takes for one thing to get to the next point A to point B. So here is, if you've ever been to St. Louis, you can see where Forest Park is, and there's the zoo all the way on the right side of the screen. If I start my morning at conference, which is basically right around here on the right side, and I need to get to our satellite office, which is about 20 minutes away, sometimes 40 minutes away, you can see the different traffic patterns that I might hit along the way. It's pretty much the same concept. So, when you think about these parameters on the nerve conduction tests, the latency is how long it'll take you to get from point A to point B. How fast will we go is the conduction velocity. And are you driving a Tesla or are you driving a jalopy? It's the amplitude. The how strong is that signal? And again, this is point A to point B. So this is a sensory nerve test. So this is assessing across the wrist for the median nerve. So they're going to stimulate the median nerve in this black electrode here. And it's going to go from the left to right on the screen. And you're going to be recording on the index finger the sensation there. So again, pretty old picture, but it does the job. So how long does it take to get from the index finger to the median nerve? Or vice versa, how long does it take to go from the median nerve to the thenar musculature? That's your latency. So this is actually my own hand that we recorded for an article, similar kinds of illustrations. So um, every lab is different with their normal values. Just in terms of thinking about kind of classic articles that talk about normal values, the electrodiagnostic criteria for carpal tunnel syndrome are distal motor latency of greater than 4.5 milliseconds and a distal sensory latency of greater than 3.5 milliseconds. Again, this is how long it takes to get from point A to point B. And then here's a classic article from Dr. McKinnon looking at the testing criteria for cubital tunnel syndrome, when she looked at her elbow flexion compression test, which is an excellent clinical examination maneuver, and compared it to electrodiagnostic studies. And the criteria is typically if the nerve goes less than 50 meters per second across the elbow, that is suggestive, if not diagnostic, of ulnar nerve compression at the elbow or cubital tunnel syndrome. Again, that could be 45 in some labs, 55 in other labs, but I just wanted to give you a general ballpark. But the nerve study is not infallible. It's looking at usually the best running fibers. So this is a so-called reporter in the sky pitfall. So if the reporter in the sky doing the traffic report is looking at only the fastest moving lanes of traffic, it's going to say everything is okay, and it's going to ignore the lanes of traffic that have pileups on the bottom part of the screen. So those nerve conduction studies, the latency and the conduction velocity, depend on the first recorded impulse picked up from those large myelinated fibers. And again, looking at this traffic analogy, the large myelinated fibers are running really quickly, but you have no idea that these thinly myelinated smaller fibers, which typically are responsible for pain, are not being picked up. And this is why a lot of patients start with pain before they come with florid weakness or sensory deficits when they have early compression. So really have to trust your examination. Your clinical exam will get you all the information you need to help diagnose and localize a lesion. So there are important caveats. There are no electrodiagnostic correlates to pain and paresthesias for the reasons I just mentioned. These are typically smaller and lesser or completely unmyelinated fibers that won't get picked up by the nerve study, which is going to pick up the best runners in the pack. And the nerve studies typically reflect the pathophysiology. Early on, carpal tunnel is a focal and demyelinating process, but if you let that go on for years and years, that leads to axonal loss. Cubital tunnel is a combination of focal demyelinated compression and traction that leads to axonal loss after early on being like a dynamic ischemic condition. And then you can see Guillen's canal is axon loss. Neurapraxia is a demyelinating conduction block in the setting of a low-grade nerve injury. An axonometic injury, in which you have a higher severity nerve injury, does have axon loss on your nerve studies. So one of the analogy that tends to resonate pretty well with most people is you're thinking about, again, getting from point A to point B, and you have a pack of runners. The conductional velocity and the latency only record the fastest runner's speed and time. So the person leading the pack in this race, that's going to be reflected in the conduction velocity and latency. But the amplitude is that the whole team is finishing, because the amplitude tends to reflect the number of axons that are actually functioning in that nerve, not just the fastest one in the pack. So in the context of compressive neuropathy, conduction velocity and latency again are the fastest runner speed and time. So that's looking at in a scenario of early carpal tunnel or early cubital tunnel. But after a period of time where that compression on a nerve becomes so severe that there becomes some internal fibrosis or scarring in the nerve, and you start to see those things like thenar atrophy, FDI weakness, just static 2-point changes, that is reflected by the amplitude. So the number of functioning nerve fibers, the number of axons, that directly relates to your advanced clinical findings in the settings of longstanding carpal tunnel syndrome and cubital tunnel syndrome. So this is a great paper from Dr. McKinnon and Holly Power, who was a fellow here at the time, looking at the correlation between grip strength and pin strength, so that's figure A and figure B, and CMAP amplitudes. And you can see there's a very linear relationship. The worse the CMAP amplitude is, the worse the grip strength is, and the worse the pin strength is. So here's an example on a nerve study. So the amplitudes you can see here are on the right. Those the you can see the waveforms here, and you can see the bottom to the top is the amplitude. And this is a conduction block of a healthy nerve because you've got normal amplitudes, okay? Seen over here in this top table on the second to right, and it's far over the normal amplitude. But then if you look across the elbow, which is the bottom row of this table at the bottom, the velocity across the elbow is 42 meters per second. So there's a conduction block, as reflected by the 42 meters per second, of a healthy nerve, which is reflected by these normal CMAP amplitude levels right here. Now look at a different case. You can see that these CMAP amplitudes, which are illustrated with the italics and the underline and the bold, and then you can see it on the right side with these waveforms. Look back at those waveforms from this last patient and then go back to these, and you can see how small that waveform is. And then on top of that, you have conduction blocks at the wrist, so across Guillen's canal, and across the cubital tunnel of 21 meters per second. So this is a conduction block at two levels, as reflected here in the meters per second, of an unhealthy nerve, as reflected by the axons, the CMAP amplitude loss. So now that you know a little bit more about the nerve study, you really do want to think, do you really need that nerve study? So the group from Michigan looked at the added costs. So on average, at least back in the 2010s, it was an average of $1,000 to the cost of care and $112 out of pocket. It's not completely accurate. There are a lot of false positives, and there's been a lot of work in the setting of carpal tunnel syndrome for the clinical decision-making tool, the CTS-6. So if you had a CTS-6 score of 0, there were still 40% of patients who had positive electrodiagnostic findings. And the sensitivity of electrodiagnostics for cubital tunnel is not perfect. It can range anywhere from 37 to 86%. So, and also there's the element of it's an intimidating test for a patient. If you, as the ordering provider, have not had one of these yourself, it probably behooves you to go and ask one of the electrodiagnosticians just to do a limited study on you so that you at least can tell the patient, you've had one because you want to know what it feels like if you're ordering this test. Um, and you understand what they're about to go through. But clearly, there is a role for these tests. I guess for you, do you want to make or confirm a diagnosis? Are you trying to look at severity? And are you trying to identify concurrent or contributing pathology? I would contend a patient with straightforward carpal tunnel syndrome, classic textbook, without any concern for either neck or ulnar nerve involvement, probably doesn't need a nerve test. Maybe get an ultrasound, but may not even need an ultrasound. And Dr. Lee will talk with you about that in the next talk. But if you're looking at it to, look for competing diagnoses or to confirm, severity, I certainly think there's a role for the nerve study. And then in the context of nerve injury, as opposed to compressive neuropathy, as if you have lower grade axonometic injuries and demyelinating injuries, the neurapraxia, that's going to be seen with your conduction velocity and your latency. But when you have the more advanced injuries in which the more axons inside the nerve are involved, that's going to be reflected in your CMAP amplitude. So let's get down to the nuts and bolts of the test. I mean, this is what patients think is going to go on when they have their nerve test. So then this is the nerve test, the EMG part, is when they actually put the needles in the muscle. So what I talked about before with the nerve conduction studies, now this is actually getting the needle into the muscle and seeing what kind of response there is in the muscle. Really talk to the person doing the nerve studies because I think that, if they understand what you are trying to look for, and then they also in turn can tell you what they saw. That'll help inform, your conversation with the patient. And then know that these studies, again, are not infallible. They do have their limits in terms of it's only as good as where if the needle's put in the right place, and they know what you're looking for. So here's an example again from that classic textbook looking at the different phases. So when you put the needle in the muscle, there's that initial kind of when you poke the needle in, that's your kind of resting phase, and then you ask the patient to recruit or to contract the muscle, and then you're going to see the response and the motor unit patterns. So here's an example of my colleague at the time, Dr. Colorado, putting a needle into my thenar musculature, and the insertional activity is right when that needle goes in. There's a split second moment where it can detect if there's some kind of abnormality in the muscle. Now, it's pretty non-specific, But then as the needle is just kind of in the muscle and you're not asking the patient to do anything, you can look for signs of denervation. And those are the fibs and sharp waves that happen early on. And we'll talk about that more later. Now, if the nerve injury has been there for a long, long time, and denervation related atrophy has already kicked in, you're going to start to see different characteristics when a needle is just resting, well, is in the muscle in the resting phase. Then there's that activation phase where you actually ask the patient to use the muscle, and then they can quantify and qualitatively assess how much activity is present, and does it look like something that's a normal muscle? Does it look like something that's an injury that's trying to recover, or does it look like something that where there's nothing at all? So the fibrillation potentials, and these are the fibs and sharp waves that you'll hear us talk about, are reflective of individual muscle fibers that are deprived of their innervation, and they spontaneously depolarize and generate these very rhythmic action potentials. They can occur after 1.5 to 4 weeks, typically after this Wallerian degeneration process has fully come in, reflecting denervation and trying to clear the way for reinnervation. They can be present for months. We've seen them present typically in the traumatic nerve injury setting for 9 to 12 months, sometimes longer. But then all of a sudden they're gone if you don't have any reinnervation. And then if the fibs and sharp waves are gone, you're probably not going to have a chance to reinnervate that muscle. And just, if you're curious, they reflect the muscle fiber hypersensitivity to acetylcholine and extrajunctional acetylcholine receptors. So I think that we all think of the nerve tests as, the EMG as this very objective and quantitative form of measurement, but it's actually quite different than that. You're looking at this. Hold on, I have one slide I want to pull up here. Let's see. I have a hidden slide that I want to show you guys. Let's see, unhide. Here we go. So you want to look at these recruitment patterns. I'm going to show you a couple different ones. I've recorded these on my phone because I didn't want to have to go to YouTube and show some ads and stuff. So hopefully you can hear and see this. So I'm going to pause it. You're going to look and see this pattern filling up on the screen, and then you're going to listen to see, to hear how that muscle sounds as it's starting to fire. So you can hear there the muscle getting a full-on recruitment. But in the setting of a nerve injury, you will hear some alterations, and this is a pretty characteristic one for an altered pattern. And you can see how, if you look at the different waveforms, the one on the top has this very dense and full pattern. While you can hear and see this one firing, look at the space between the waveforms. And then here's one that's in early reinnervation. And look at the height of those waveforms and how they're still also spaced apart. And the pattern is, as they say, not full. Again, it doesn't sound like this one did. And then here is as after you have more reinnervation, more motor units coming. It's not normal, but it's certainly better than what you've had in the early reinnervation one. So I got those suggestions from Brian Crum, who is an electrophysiologist at Mayo Clinic. So for me, that's when it started to click of, oh, this is a very qualitative assessment. It's not just quantitative. So to get back to how you want to use these tests, what I want to know in the context of a nerve injury is, where is the nerve injury? How severe is it? Do I have chances of spontaneous recovery? And if not, what are my options? So to help answer these questions, where is the nerve injury? That's the distribution of findings on the nerve test. Which muscles are involved. Is this a high median or low median? Is this a high ulnar or low ulnar? Then how severe is the nerve injury? So, your CMAP amplitudes on your nerve conduction tests, if those are CMAP amplitudes like 0.5, like I showed you earlier, that's pretty severe. And then on the EMG, are there any motor units present at all? If there is nothing, then you think this is a pretty severe injury. If there are 3 or 4 units present, if it's pretty clear there's something going on, maybe that's something that is not as severe as a, full-on cut nerve or a high-grade axonematic injury. Will spontaneous recovery occur? The CMAP amplitudes, if they're higher, suggest that yes, there's probably a good chance. And is on the on the EMG, the capacity to reinnervate is going to be reflected by the fibs and sharp waves. If there are no longer fibs and sharp waves, there's no way that, and you have a low CMAP amplitude, it's very small chance of getting any meaningful recovery. So, if spontaneous recovery won't occur, what are your options? Many of you are familiar with the concept of nerve transfers, not the focus of today's talk, but that can help assess the health of a potential donor muscle tendon, a muscle nerve unit. And this is work from Scott Wolf's group at HSS looking at if you look at the recruitment pattern on EMG, if it was full or even slightly decreased, you're still going to get a high chance at meaningful recovery, as graded by an M4 or 5 score. But if there's a discrete recruitment pattern or no motor unit recruitment, your chances are going to be significantly lower of getting a good result after your nerve transfer. So I wanted to bring it to a close there just because I know we're getting close to time and I wanted to leave a little time for discussion or cases. But this is a review article that I wrote with Dave Brogan and our electrodiagnostics partner at the time, Dale, Colorado. That pretty much covers what I talked about here. And I like to think it's pretty understandable. And if you have any questions, I'm happy to take them now or later on. And this is just a reflection of that quote from Dr. Dellin, that these really are a reflection of your clinical examination, extension of your physical examination, and you really need to be thoughtful in how and when we order these and how and we interpret it to help our patients. So thank you for your time. I'll stop sharing my screen here and turn it over to Warren.
Well, thank you very much, Chris. I appreciate it. And I'll introduce Neil Lee and ask him to share his slides. And while he's getting them ready, Chris, one quick question for you. Why do we seem to find these nerve studies are more accurate for some conditions than others? Like we would think that it would be fairly similar across, but I think it's harder to pick up cubital tunnel than it is for carpal tunnel. And then it's really hard to pick up some of the deeper nerves if you're thinking about pronator kind of changes in the radial nerve. Just a two-sentence answer to that if you can as we move on.
I think fundamentally cubital tunnel is a different condition than carpal tunnel because of the traction element, in addition to the compression. I think median nerve in the forearm is challenging because it tends to be a bit deeper. Same thing with the radial nerve in the forearm. It's just harder to pick up some of those things. And then the localization of the muscles can be more challenging without ultrasound guidance.
Okay, thank you. So Dr. Lee is going to talk to us about the use of ultrasound and maybe some of the benefits where it can pick up some things that the electrodiagnostics maybe have a little bit more of a difficult time. So, Neil?
Yeah, thanks, Dr. Hammer. And that was a great segue to this talk. So I'm about 4 years into practice. When I came to Duke after my fellowship at Mayo, um, I realized that imaging is really important because of what we just talked about. The electrodiagnostics typically don't give you the whole picture. And I thought MR neurography, or I thought this and that would give me the answer. And then over time, I realized that's just not translatable to all institutions. So really embraced the use of ultrasound in my clinic to really give me that extension to the physical exam. And I think, like Dr. D said, your history and physical is the most important of any of these pathologies. We are using ultrasound and electrodiagnostics just to see if our hypothesis is confirmed. And at least for ultrasound, if we get a visual confirmation of what that nerve is doing in real time, to both serve our diagnosis purposes and also for the patient to have a sense of the understanding of what a nerve actually is. And so for this talk, we'll look at, why reach for the ultrasound at all? And we know it, POCUS for the ED, POCUS for liver. How do we apply it to nerve? What can we use it for as far as cross-sectional area, as far as looking into the fascicles? How has it been validated? It's been used quite a bit for carpal tunnel, but can we use it for cubital tunnel? Can we use it for radial, Peck Minor syndrome? Can we use it for thoracic outlet syndrome? And how does that help us determine how healthy the nerve is? Can we look at the fibrosis? Can we look at impeding structures? And how do we apply that information to the electrodiagnostic study we just got back? If the amplitude is low and the cross-sectional area is high, I'm thinking that not many axons are getting through. It's really swollen, really not healthy nerve that probably should act on sooner overall. And again, it's comfortable, it's repeatable. It doesn't require us to stick needles into the patient and they tell me, I never want that study again. So to start with, what is normal? And so thankfully at Duke, we have one specifically, Lisa Hobson Webb, who was probably one of the first to describe cross-section area use in carpal tunnel in the early 2010s, published it in a bunch of neurology journals, and it's picked up into our field as well. And Talia Gonzalez, who's the first author of this kind of review, is another one of the neurologists at Duke. And so with their expertise and how they do the electrodiagnostics into the ultrasound practice, it really helped frame how I see it. But ultimately, when we look at this, on the left-hand side, it's a cross-sectional or short axis view of the median nerve at the level of the wrist, let's say. And we want to look at a honeycomb appearance, which looks at the epineurium, perineurium of the fascicles with inside the nerve. And so you can see it's honeycombed. You have the different fascicle shapes on the cross-sectional area, and on the long axis, you can see the epineurium take fold. You can see the different fascicles as well running longitudinally across the screen. When we look at ultrasound in carpal tunnel, understand this talk is beyond carpal tunnel, but in carpal tunnel is a great threshold for how we should understand this at baseline because it's pretty accessible for anyone to do. And looking at how it's been diagnosed at this point is by cross-sectional area. So below on the bottom left is looking at a review, just saying what are the different articles that said what is the normal cross-sectional area of a median nerve across the arm under ultrasound in the short axis view. And ultimately, the weighted mean for these is about 8.8, 8.5, so ultimately less than 10. And so I think generally we could say that a normal nerve, median nerve at the level of the arm should be less than 10 millimeters squared. And so we can assess this again at different levels, thinking if we think it's pronator syndrome, look at that from the mid forearm, carpal tunnel at the level of the wrist as well. And then thinking about cross-section areas in absolute value, some patients, it may be different. And so in some circumstances, having an internal control for those values may be helpful. So by doing so, you can think of a wrist to forearm ratio in the carpal tunnel. And so if you measure a cross-sectional area at the wrist, that may say it's about 15 millimeters squared, and you travel at least 15 centimeters up to the mid forearm, and you measure that between the FDP and FDS, and you measure about 8 millimeters, it's about two. And you could say that within that framework, greater than two, or to be more sensitive, greater than 1.4 in some studies, that could be considered carpal tunnel as well. The other thing about ultrasound is that it may not always be, carpal tunnel. And you can always think about what other pathologies could be causing this neuropathic discomfort in the median distribution at the wrist. In the top, in A, it's probably a normal median nerve. You see that honeycomb appearance. In B, you see a flattened nerve potentially from the likes of a carpal tunnel. In C, it's kind of looking at a bifid median nerve. And then in D, it looks you can lose Doppler on the ultrasound and it shows a persistent median artery within the nerve. So just given other pathology that it could be. Some things that could also be in real time, just looking at a lipofibromatous hematoma, just the different fascicle sizes that's shown to the right here. It looks more swollen. Again, increased cross-sectional area, but then it's like 30. And it's like, is that normal? Is that a tumor? Is that a schwannoma? Can I use ultrasound to distinguish that between that and hamartoma? And you realize that under MRI scan, it's a little more difficult to really appreciate that. And I think real-time imaging is really helpful to get that full extent of what this could be in both the long and short axis. And again, you look at through accessory muscles, tenosynovitis, or flexor tendons, really give you that differential of what it could be, and really for the patient to see it as well. Because at least from my standpoint, doing this together with the patient is really the most helpful thing as well, as opposed to just reading values off of paper. As we move to cubital tunnel, as we touched upon, it's a different pathology. And so I think as we look at what cubital tunnel could be, is it a traction issue? Is it a accessory muscle issue? Is it a compression issue? It's really a point of getting the whole picture of the nerve across the elbow. So really important as we scan around the medial epicondyle, we go 2 centimeters above, 2 centimeters below. But your goal is really get a morphology picture. What is this nerve doing within that site of travel? And so you want to get the point of maximum enlargement to get a sense of, okay, before the cubital tunnel or at the arcade, is it high up? Is it in the arcata stratus causing that deficiency? Is it at the FCU? And really gives you a sense of where is this compression happening and how to compare that to an area that may be normal to give you not only a cross-section area, but also, again, that ratio to help you confirm whether there's some sort of compression neuropathy ongoing for the ulnar nerve. And again, this is looking at one of Fowler's review articles saying if normal is less than 10 for carpal and cubital, theoretically, the larger you get in the cross-sectional area from mild to moderate to severe, more than 14. Dr. Hammer published on this as well, the more severe the cubital tunnel or carpal tunnel could be. So it really gives you maybe a sense of the diagnostic extent of what this could be, and that can further helps hopefully inform the electrodiagnostic studies. Because as we may see in some patients, the EMG or conduction study might be normal, especially in the younger population. The ultrasound maybe give you that extra sense of what it could be as well. And so again, measuring the largest cross-sectional area, this is just an example of 13.4. And again, just rule out other things. Is it in epitrochlear areas, is schwannoma osteophytes, subluxation, snappy triceps? It really gives you that real-time feedback so the patient can understand what's going on, especially in those revision cases. When you have a patient that has to come back to see you after multiple revisions and what should we do next, and have them understand why this is still ongoing. So as you pull it all together, we kind of look at how this may be coming back on a study you may get. So it may say left median wrist is 13.4 millimeters square, forearm is 7.5, and the ratio is 1.79, being greater than 1.4 to give a diagnosis of an sonographic confirmation of carpal tunnel, let's say. What's interesting in this same patient is the right median, they measured at 3.8, and then the wrist is 12.4, and that ratio is 3.26, which, I'm not sure what to interpret that. I think we take that again in the context of the patient and their physical exam, but I think also being wary that don't take every value at surface at face level, have some thought that why is less, it might be just a general process. Maybe they have an ongoing pathology, but it's not always the most, absolute thing. So just really take it into the exam and clinical picture. Similar left ulnar at the elbow level, 23.7, a cubital tunnel, 7.2. So you get a sense of how they're measuring the greatest cross-sectional area and getting the normal control for that patient. So just to kind of give the overview, carpal tunnel, the wrist inlet less than 10 and then greater than 10 to 12, probably something abnormal, carpal tunnel-esque. Similar kind of values with the cubital tunnel, and then utilizing the wrist to forearm ratio. Again, you can use the ratio for cubital tunnel as well. You can look at the elbow to wrist ratio, but mostly it's been most validated, let's say for carpal tunnel, and to some extent, as you get more comfortable with this, it could be really useful to save a patient from an EMG for cubital tunnel as well. So I think a brief aside, just to say, if you all were intrigued to kind of start ultrasounding in your own practice, it may be intimidating if you've seen it, whether it's in the obstetric's office or with the anesthesiologists. There's a lot of buttons on the screen, but really it's really quite simple. At the end of the day, you want to find hopefully a linear transducer. It's just the one that's straight, not curved. And you want at least to have some level of megahertz amplitude. So the higher the number on the probe, the more power there is to see, the more detail there is. And so that only goes for as how shallow it gets. That's just another interpretation. But the more power, the higher the number, maybe the better you can see the nerve. The gain is just really subjective. You can turn the dial to see if it's brighter or shorter. And then you really start starting with the short axis, cross-sectional first, and really want to make sure that your depth and your focal zone are appropriate. So I'll give you the example here. And so if you look at this screen, you have what the ultrasound machine will have as your focal and your depth here. So you want to put your depth where you want to see the nerve. So if it's carpal tunnel, you want to have your depth pretty shallow, maybe at 2 to 3 centimeters, and your focal zone pretty high above. And as you get down the forearm, that'll have to change. So again, as you can see here, the quality here of the nerve is much better when you have it centered here as opposed to something that's down lower on the depth in the focal zone, as opposed to that blurry image as well. Another thing we have to think about is with the probe itself, how are you holding the probe? How are you utilizing it? Because you can tell, like, if you start to deviate, if you start going off axis, it can really distort your image. So I think it being kind of just having some practice holding the probe, playing around with your own forearm or somebody else of friends is super helpful. Just get comfortable holding the probe. And I also treat it's just a function of how the waves are hitting the structure. So if you kind of wig and wag the probe, it changes the image. So really, it just gives your own taste of what you want to see, but you really want to see that honeycomb appearance that gets distorted depending on the pathology. And so this is just a picture of myself in clinic, just to highlight a couple of things. So when I first started doing this, it behooves you to just not conform to the patient, but have the patient conform to you. And what I mean by that is make sure they're comfortable, make sure you're comfortable as well. Don't just bring the ultrasound machine next to them in the corner and think you're going to get a good study. Really take the time to set them up for success. So I have the patient move to the center of the room. We get a hand table next to them, have them turn their body. I bring the machine as close as possible that I need it so I can utilize a keyboard and have really easy access to both things. And if I look at this keyboard, all we want to see here is just there's two knobs, and all the machines are different, but they'll always have depth and focus. So depth, focus, some gain, and some zoom function, and then a freeze button. But that's really all you need to really focus on, I would say, to really get started on this practice, to really advance maybe your physical exam as well. And this is just a look at the radial nerve. I think this is just at the kind of the antecubital fossa level, tracing it out, to the arcade, to the leash, into the supinator to see if it's being swollen or not, to help the patient understand the pathology. Again, you can go higher up to the spiral groove, and for that purpose, this is a patient who came in after a radial nerve kind of injury from a humerus fracture of reduction of plates on, nerve is injured, kind of a common story for us. And if you do a scan in the clinic, you can just see the nerve is somewhat dense, a little swollen. You see this hypoechoic rim here. And as you trace it distally into the groove, it really flattens out. So, really concerned that something's pretty severely going on with that nerve that I really don't have much sense it's going to recover on its own. So just kind of pushing the patient towards maybe an operative approach, given the lack of function and given the time frame at this point. But giving me that next step for the patient to understand what's going on and how to indicate them for surgery. And this is just an example of how do we take this up to the neck. Again, looking at a lot of patients with thoracic outlet syndrome who you realize that the EMGs and electrical conduction are pretty normal for those patients. MRIs maybe are equivocal, and maybe we can use ultrasound just to see if the scalenes are pushing on the neck at certain places. Is the plexus more swollen than others? And it's been helpful for me to really understand this pathology better. So, in summary, you can use this throughout the arm to really supplement what the nerve study is showing you. But again, you can start from the neck, scalene triangle, supraclavicular, pec minor, infraclav, above the cubital, around the arcade, down to the pronator. So it really helps expand what you can tell superficially, and then to get to a little more depth. Just a few more minutes, just a couple more minutes about just nerve injury, kind of taking cross-sectional area to the next step of when we see nerve injuries and amplitude differences and differences in recruitment patterns that Dr. D talked about. Can we correlate that image, that kind of picture on the study into an image on ultrasound? And what we've realized, kind of doing some reviews in the literature and in our own practice, is that you can see not only the increase in cross-section area, but really the fascicular disruption with the higher ultrasound, with the higher frequency ultrasound probes, high resolution ultrasounds, that you can see that change in fascicular architecture and the loss at that fascicular structure. To really push us to make a decision sooner, because ultimately, time is muscle, and making a decision for patients' well-being in a more timely fashion to their best benefit. And all, but this is just a table just to point out that the fascicular disruption was our highest ability to say you have a high grade nerve injury, you have a 3 or a 4 versus maybe a 2 or a 3 or a 4. To some degree, a 5. 5 is maybe more obvious than a 4 on a Sunderland classification, but just giving us that difference between high and low grade injuries. And again, if we look at this 22-year-old gentleman, gunshot injury, comes to see us 2 months out, get a nerve study, he has no function, put an ultrasound on him, and really you just see a bunch of scar across the arm where he was injured. And so pretty quickly you can make a decision that this is a high-grade injury, loss of fascicular architecture. Let's go and explore intraoperative monitoring to maybe confirm that, and then ultimately perform a reconstruction if indicated uh, overall. And so just the last point is as you get maybe more facile, and if you want to code for these, there is these building codes. Ultimately, 76882 is more for a limited ultrasound that I use the most versus a full report on the 881 code. And again, as I get more facile, doing more diagnostic injections has helped my practice as well to help get a sense of is that the compression site, will this help them kind of get them any relief? And so just again, I think ultrasound again does not replace the physical exam or history, only supplements it, helps to interpret the electrodiagnostic exam. And then I think ultimately for me, the most meaningful thing has been patient education, understanding not only their pathology, but also in the recovery process, we can track out how well they're doing as well postoperatively. And so I'll end with that.
Well, thank you very much, Neil. Outstanding presentation. As we get ready to turn over, I'll introduce Miss Megan Harari, and I'll let her start sharing her slides. But Neil, briefly kind of explain the advantage of you doing this rather than just referring them to the radiologist that does it, because a lot of patients or a lot of physicians and APPs don't have a machine or easy access to one, and they say, well, should I just send the patient to the radiologist to get this? Do you think that's as beneficial or not?
Yeah, that's a great question. Um, I think as surgeons and as APPs, as we see more of these patients, we really have a great understanding of where their pain is coming from, how they're localized, and how they're talking about it. And I think applying context to what they're telling us with the ultrasound is super helpful. So I think the clinical exam and then understanding the morphology. We're not looking at just a point. So I think what is confusing, I want a landmark to show it, but I want to see the whole picture. I want to see how the nerve is traveling, how it's interacting with other structures. And to that extent, it helps me plan out the surgery and also tell them what we're going to do intraoperatively.
Yeah, thanks. I always find it kind of the dynamic portion of this and being able to move the probe around very helpful as opposed to just looking at a static image in the chart.
Yeah,
So appreciate
absolutely.
that thought. So with that, Megan, I'll ask you to start your portion of the presentation, and then we'll have a little discussion at the end.
Sure. So, thank you for inviting me to be here this evening. My name is Megan Harari. I'm a nurse practitioner at Yale, and this is our amazing peripheral nerve team. It currently consists of Dr. Hill, myself, and Chelsea Taylor, who is our occupational therapist that we work with. We see all the complex peripheral nerve injuries at Yale. We have a pretty robust practice right now with a high level of volume. In my own clinics, I typically see about 90% of nerve patients, and about the other 10%, I would say, are hand trauma. So I know we've talked about the imaging. I am going to kind of focus this in onto, as an APP, what are some of the things that we're going to be looking for when we see these patients in clinic, when we see them as potentially the first provider intervening, what are some of the red flags, and where do we need to go with that information? So why me? Why do I, as the APP, need to know this stuff? So if your practice is anything like mine, you know that the surgeon schedule is pretty backed up. So for that reason, we as the APPs are often first to see these patients. So we're going to be getting them in, we're going to be triaging them, we're going to be looking for some of these highly time sensitive injuries, whether they are going to need nerve reconstruction or whether we're going to be treating them non-operatively. So as we've talked about a little bit before, the most important diagnostic tool that we have is not the EMG, it is not the ultrasound, it is the patient. We need to start with the patient, listen to our patients. The majority of the time, our patients are going to tell us what is bothering them. They may not have the words for it. Nerve pain can be very weird, very hard to describe, but they, in their best way possible, will try to tell us what is going on. So to take a few steps back, I just want to go over a few of the most common compression points that we need to be looking for. So in our median nerve distribution, we are going to be looking at carpal tunnel. We're going to see this in probably a large portion of our population. A lot of times patients are going to be coming in saying, my mother's aunt's cousin told me that I have carpal tunnel because I work at a computer. And lo and behold, we're going to find something completely different once we start our evaluation. In the forearm, we're going to be looking for pronator. These are going to be our, like your casino workers that do a lot of card dealing, potentially your bakers that are doing a lot of rolling dough, anyone that does a lot of repetitive motions in pronation. And lastly, sometimes we'll see compression at the ligament of Struthers, but that's not too common. So our ulnar nerve compressions, these are our cubital tunnels, and this is pretty um, common in patients that we see that do repetitive elbow flexion. I'm also going to see this in people that sit in that flexed elbow position, people that are wheelchair bound. Every now and again, I will see patients coming in that either had a hip replacement, a knee replacement, something that required them to be on a walker or crutches for an extended period of time. And now they're experiencing either carpal tunnel-like symptoms or cubital tunnel-like symptoms. And don't forget about assessing that ulnar nerve at the wrist as well. It is not just at the elbow that you're going to see it. If you see a patient coming in with advanced wasting of that first interosseous dorsal space, you need to start thinking about that ulnar nerve. And then lastly, our radial nerve compression. So these are patients that you may see come in with the good old Saturday night palsy. They're going to say, I woke up, I can't extend my wrist. What is going on? That's always a great one that I love to educate people about. We're going to be looking for radial tunnel syndrome and making sure that we do not confuse it with lateral epicondylitis. They do have a fair amount of crossover when you're assessing your patient, but there are some specific ways you can really kind of narrow that down. I'm not going to talk too much about brachial plexus, though I do love this picture. But it does make me want to say, think upstream. When your patients are coming in, when you're looking at their hand or their forearm or their wrist or their fingers, and you're talking about the numbness and the tingling that they are experiencing, don't forget to look upstream. Everything is coming from the neck. Oftentimes, patients will forget to tell you that years ago, maybe they had a C4-5 fusion or they were in a motor vehicle accident and the right side of their neck has always hurt since then and things always felt funny. It's a lot of history taking. It's a lot of asking the right questions. So now what? You've got someone sitting in front of you. This is the first time they're coming in and you're thinking, okay, where do I go? So I have a standard format that I follow every single time I assess a nerve patient. I do the same format whether they are a new patient, and I do the same format whether they are coming back postoperatively or return for some reason. I do it the same time or the same way every time for a couple of reasons. One, for thoroughness. Two, because that's just how my brain has been trained now. And three, because especially with new patients, I may start looking for something, and the more I ask and the more I test, the more I find. So this is the nerve sensation exam that I start with. I do have it preloaded as 10 out of 10, so I can modify it as I go. And then I go on to their motion and the provocative exam. And so as I start looking at these, and certainly as we start looking at patients preoperatively and then postoperatively down the road, it's nice to have the consistency. And the surgeon that I work with, Dr. Hill, and I use um, the same evaluation method, which is really nice because I know that she can look at my note and understand exactly what I was thinking. I can look at her note. And so for consistency of evaluation, this pattern makes it very beneficial. So while I'm going through and I'm doing this test, it's pretty extensive. It takes some time, but it also gives me a chance to talk to them. It gives me a chance to look at them. I am evaluating how they are responding to my questions. I'm evaluating what hurts them, evaluating the words that they're using. And it's all putting the entire picture and all the pieces of the puzzle together. So even though I have that method and I go pretty stepwise when I do my own assessment, figure out what works for you. Figure out what method will work for you, whatever is going to stick in your brain. These are just a quick reference guide that I put together a while ago, looking at these nerves along with some of the big red flags that we need to keep an eye out for when you start to see these things like thenar atrophy, that first dorsal interosseous atrophy, finger drop. These are things that need to be triggering in your brain. I need to escalate this to the providers or the surgeons that I work with because this needs to have a little more looking into it. So you've seen these patients, you have done your exam, you have taken an amazing history, you know everything about this person, you know what they like to order at Olive Garden, you have got a full idea of where their nerve pain is coming, or so you think you do. So now you're going to go ahead and order your EMG. Now, when you order your EMG, this is a piece of the puzzle. Um, you are going to use this to supplement your history. You're going to use this to supplement your clinical exam. This is a screenshot of what our EMG order set looks like. So as you can see, there's a lot of different ways that I can sort of modify it. But the most important thing is that comments section on the bottom. When I go to order an EMG, I am putting in there, what am I thinking? What am I concerned about? What nerves do I want that person to look at, whoever's doing the test? Um, by doing that, it is going to help that test get tailored to exactly what I want to know, which is really going to help us provide the best clinical outcome for this patient. Um, Sometimes patients will be really great advocates for themselves and they will do a wonderful job talking to the EMG provider to get exactly what they need, and sometimes they're not. So I use this comment section all the time so that they know what I'm thinking. And in that same thing, if I get this EMG back and I do not understand this, or it is not correlating with what I thought I saw when I saw that patient, I'm going to send a message to that provider, or I'm going to text that provider and I'm going to say, hey, can you explain this to me a little bit? Because this is what I saw and this is what it's showing. And for me, it's not going together. So can we talk about this? These are collaborative relationships. These are awesome working relationships. If you have a great team and you can get patients in a timely method, those are really just wins for everyone. But not all EMGs are created equal. This is only going to depend on your patient participation, the details that you gave in that order set, the experience of the EMG provider, and all those things. So you've got your EMG back and you're thinking, this doesn't quite correlate with the patient that I see sitting in front of me. So this is a quick little clinical sort of story of a patient that we saw recently. This was a 53-year-old guy. He had come into us because he'd previously had a bilateral endoscopic carpal tunnel release. His right hand was doing fantastic. His left hand was killing him. Now, on the surface, this man had had a successful surgery by a wonderful surgeon. Everything was going great, but clinically, he was suffering. He was in 10 out of 10 pain. He had poor grip in his hand. He had been telling people things are not right. I don't feel good about this. And he hadn't gotten answers from the providers he had seen prior. So after his surgery, he had started doing occupational therapy. The occupational therapist had also shared that the patient was really concerned. So here we are. We have a patient who is telling us what he is feeling in his body. We need to listen to him. It may not correlate exactly with what we are seeing or what we are thinking in our testing, but this person is telling us something is wrong. I know my body and this is not right. Our occupational therapist thankfully arced this up to another set of providers, and he ended up in our clinic. So on exam, this is what we found. The right hand did look beautiful. He had had that endoscopic tunnel release. He had no complaints. His left hand was a different story. His index and his middle finger and his thumb to some degree were really suffering. He had really minimal sensation, if any, in any of those digits. His Tinel's was very provocative. So he was now 5 weeks post-op at this point when he came to see us. So he started to have early signs of CRPS. I will not get into that. That's a whole other thing. But we were getting pretty concerned about him. So we brought him to surgery, and what we found was a extremely compressed median nerve. It was contused at the transverse carpal ligament. The distal segment was an incomplete release, and there was scarring in there as well. So here on the left is just there to show the direct, positioning of the hand. And then here on the right, a bit more zoomed in, will actually show where the injured nerve at the endoscopic carpal tunnel release entry point was stuck to scar. So another element of the exam that I always use, this is our pain scale. This is something that we always give to patients. We find this very helpful because there's a multiple levels to it. On the top, you've got all the descriptive words. Some patients will choose every single one. Some patients will be very particular on what they choose. If your patient is choosing every single descriptor on the top, that is a clinical indicator things are not going well for them. So you can see here on the top on March 5th, this was the first time we had seen this patient. He was 10 out of 10. This was having a huge effect on his life. His quality of life was pretty significantly decreased because of this injury. We ended up taking him to surgery shortly after that. And then here on April 24th is when we started seeing him back. Again, this pain diagram, he's not doing wonderful. He is not 100% by any means just yet, but he is significantly improved. Another thing that he has also been participating in is mental health support and group therapy and individual therapy. This is another element of working with these patients that have chronic peripheral nerve pain, nerve injuries, things of that nature. It's a huge component of helping get these people healthy and back on track. So, in conclusion, don't treat the study, treat the patient. Listen to your patients, examine them deeply and thoughtfully, localize where you think the issue is coming from, and then use your diagnostics strategically to get more answers to your clinical question. Know the red flags, and then work really collaboratively and kindly with your surgeons, with your EMG providers. Ultimately, the goal is to give great care for these challenging patients. And so, creating an awesome team and good communication is wonderful. And as we all know, peripheral nerve is super easy, right? That's why we love it. So, thank you guys for having me here today.
Thank you, Megan. Great presentation and explanation of how you use this. As we're starting to wind down, I'd like to ask actually all three of you a question, given kind of the scenario that you described. So starting off with Megan, someone comes back after surgery, whether it's yours or someone else's. What is the role for diagnostic studies, either ultrasound or nerve studies, in someone that's had a peripheral nerve decompression, whether it's cubital tunnel, carpal tunnel, and they come back and say they're not getting better? How do you decide that I need to refer them for studies versus I just think it should be explored and I'm going to have our surgeons do that? Megan?
Yes, sorry. I was trying to make sure that my screen was getting unshared there. Um, can you say that one more time? I was trying to
Yeah.
make sure my screen wasn't getting shared
Yeah,
anymore.
that's okay.
I
So
apologize.
in the example that you showed, someone that wasn't doing well,
Mhm,
how, if you're in the clinic and you see someone that's had surgery and they're
mhm.
not doing well, how do you decide we need to send that patient back for some additional nerve studies? I need to do an ultrasound versus this patient should just go to the operating room and have an exploration. I'm going to talk to my surgeons and just get them scheduled to move forward. How do you make that decision?
It's collaborative, to tell you the truth. If I have concerns and I do not feel that something is right, what I'll often do is text the surgeons that I work with, Dr. Hill, and say, this does not seem right. This is what I'm seeing. This is what I'm finding. This is how they're feeling. Do you want any additional imaging? I think they would benefit from X, Y, and Z, and then go from there.
Chris, in your practice, how would you manage this? Someone, whether it's usually a little bit different if it's you because you feel like you've known what that looked like intraoperatively, but how do you decide the role for imaging, electrodiagnostics versus surgical exploration in someone with persistent symptoms after surgery?
So I think it depends. You mentioned the keyword persistent. Persistent makes me think that maybe it was not the right diagnosis. There could be alternative pathologies. If it's immediate worsening of symptoms, that makes me think more in the line of an iatrogenic issue that occurred during the index surgery. So I think those are two different things, but for both, I tend to fall back more on imaging. I think ultrasound is very helpful in this setting, and a nerve study, because I think that while we may not need it to shape what we're going to do and how we're going to talk to the patient, it gives us some additional data to fall back on because a revision surgery or a second surgery after a surgery that you did not expect to have an issue after is a big psychological and financial and time investment for the patient. So I think having that additional information helps all involved.
Neil, other thoughts?
No, that was great. Just Dr. D's last point about something to fall back on, more data just to support. How are they going to do? Are we going to cure them at the end of the day, or we need some baseline to see how they're going to do long term? So, and again, looking at other pathologies as well. So really ascending proximally potentially. But yeah, what Chris said. Thank you.
So, final question for you. What do you do with the patient that had surgery, comes in and says, "Oh, I got a nerve study and they told me I still have carpal tunnel syndrome"? Obviously, you're going to look at their clinical symptoms, but what are your expectations on repeat electrodiagnostics or repeat ultrasounds for someone that's already had a peripheral nerve decompression surgery? How do you use that in your decision-making process, or do you believe that's helpful? Chris, I can start with you again.
I think the ultrasound is really helpful. I think that again, it informs kind of what you. I think I know what the ultrasound is going to show, but there is a component of ultrasound that, and Neil mentioned this, that patients really like seeing. They like the touch component and they like visualizing issues. So I think there is certainly a role for me to order ultrasound in that context.
Neil?
Yeah, and prepared for the talk, I wanted to understand if after carpal tunnels, the ultrasound show improvement to the nerve. And I guess in carpal tunnels, it wasn't super conclusive because you would think that, oh, it doesn't get smaller. It might be persistent. But I would still utilize it again, just matching the patient's physical exam, their clinical symptoms with what they're actually telling me overall. Um,
And
pro- yeah, go ahead, Chris.
I was going to say, just to complement what you're saying, Neil, I mean, oftentimes when I'm ordering the test the first go around, I will say it very well may show this, that, and the other. And if you get in front of that messaging, I think it is super helpful because, like Neil was saying, there is a lot of uncertainty in the literature with regards to what a nerve study should look like or an ultrasound should look like after a release.
Yeah.
Yeah, I think it's helpful if it's worse. If it's better, but not normal, then I find that less helpful in thinking about it because is it just a chronically compressed nerve that's never going to be normal? And we normally don't get these studies because patients are improved and we don't know what 100 of them look like versus the person who still has some sort of ongoing problem or being able to identify a new problem. Megan, anything that you'd like to add to that?
Yeah, in that situation, I would, in all honesty, look further up the arm. I would wonder if there was something else that was compressed further up the pathway that was continuing to give them symptoms, even though they had that carpal tunnel release. Is that median nerve compressed in the forearm? Is it coming from further up the neck? Was the surgery helpful, but not entirely curative?
Yeah, well, I'd like to thank all of our panelists for presenting. I think this was an excellent webinar. This has been recorded and will be available for viewing on the AAHS website in the next several days, and you'll get a message, an email indicating that it can be viewed. So thank you to the panelists. Thank you for AHS for organizing this. And on behalf of Carrie and myself, thank you for spending an hour of your evening with us.
Thank you for the
Thank you.
invitation. Appreciate it.
Thank you all.
Thank you so much for having us.